Right, guys. All right, should we get started? Margaret Hang,
Second lecture.
second lecture,
Okay.
Pediatric Blunt Abdominal Trauma. Take it away.
Okay, we don't have as much graphic pictures here. Okay, so we're going to talk about pediatric blunt, not penetrating, we're going to focus on the blunt abdominal trauma today. Okay? So we're going to start with an overview for blunt abdominal trauma. We'll talk about how to manage these kind of trauma. There's clinical decision rule that we're to go over. And finally, disposition. What do you do with these kind of patients in your emergency department? Okay, who's up for your read? So, can you take it away?
A 9-year-old boy previously healthy brought in by parents for abdominal pain. He was riding his bicycle around 1 p.m. the day prior to arrival, hit a rock and fell over the handlebar. He was initially asymptomatic but developed abdominal pain around 8 p.m. and had 4 to 5 episodes of non-bloody, non-bilious vomiting overnight.
Okay, thank you. All right, John?
Vital signs: heart rate 105, 101 over 63, 101 over 63, respiratory rate 15, 99.7, O2 sat 99% of the mirror. Exam is unremarkable except mild epigastric tenderness, no ecchymosis, abrasion, rebound, or guarding.
Great. Okay, so 8-year-old boy fell over the day before. Now it's almost 24 hours out. Is having nausea and vomiting multiple times throughout the night. What would you do? Would you pain control him and go home, the pain resolved? Would you do some lab test? If the labs were reassuring, you discharge the patient home? Would you go straight to CT scan? Would you do everything, including calling the surgeons? What about UA? Okay, so as we go through this lecture, I want you to keep in mind, just kind of keep this case in the back of your head and think about what you would do. All right? So start with an overview. 8% admission to pediatric trauma centers are blunt pediatric abdominal traumas. The third leading cause of death. Head trauma is number 1. Thoracic traumas are number 2. It's much more common than penetrating traumas. And the most common mechanism is falls or motor vehicle accidents. And also, let's not forget about child abuse, okay? Especially when you're talking to the parents, if there are any red flags in the history, or the pattern injuries that you see is inconsistent with the mechanism provided. Just think about this in the back of your head. Anatomical features. What makes pediatric patients different from adult patients? What do you guys think? They're smaller. Sorry, Ryan.
I was going to say the ribs are more pliable and not as protective.
Good. So they don't typically get fractures, right? They get pulmonary contusions because it's more pliable. Okay, what else? What about?
Does they have like growth plates?
They have growth plates. Good.
Difficult to read the X-rays.
Absolutely. Okay, and that's why sometimes we get bilateral X-ray just so we can compare. Okay, Ganesh.
The liver and spleen are probably larger relative to the rest of their body.
Good. Okay. So they have thinner abdominal muscles. You know, they're not like you guys. They don't have the six-pack, right? I know you guys do. So they don't have that. So muscles are much thinner. Okay. So like Ganesh said, the solid organs are proportionally much bigger in the abdomen. Okay. So to the extent from that, the liver and spleen are not as protected by the lower rib cage. And the hollow viscous injury is much less common. It's only 2% than solid organ injuries. Okay. So for blunt abdominal trauma, we'll divide into 3 categories: solid organs, abdominal wall, and hollow viscous. Okay. And we'll start with solid organs. And let's see if this. Oh yes, it's working. Have you guys seen this before? The composition is very intimate.
Nice.
Ooh, he's bleeding. On the inside. He's bleeding badly. Let's peel this back and look at it. So this is the moment that we've really been waiting for. We want to see what happened to the spleen. That is disgusting.
Moss's punch measures at over 1,300 pounds of force.
Okay, so we start with spleen. Okay, it's the most commonly injured organ, as you just seen. Okay, typically on presentation, patient will come in with belly pain, especially in the left upper quadrant pain. If that pain's radiating to the left shoulder, that's known as the Kerr sign. And how do we diagnose this? CT, right? And there's a grading system, the same grading system as an adult. We're not going to talk about the grading system. That's what a surgery residency is for, and not for us. Okay, the treatment, but you just need to know it's low grade, grade 1 and 2. Most of the time, 90% is non-operative management. They get observed. But if the patient's unstable, if it's a higher grade, grade 3 and 4, they go to the operating room. Okay? Moving on, what is this? So right upper quadrant, what do you see there? Fluids, okay. So let's talk about liver. It's the second most common injury, but this one has the highest mortality. Look at mortality, 10 to 20%. Again, they come in with belly pain, this time right upper quadrant pain, they can have hepatomegaly. There's another grading system, it's the same as in adults. How do we diagnose this? CT, good. Labs may be helpful here, okay, especially if the AST is greater than 200 and the ALT is greater than 125. When that happens, there's association with intra-abdominal injuries. Just like the spleen, how do we manage this patient? If they're stable, if it's low grade, you watch them, you do non-op management. If they're not stable, they go to the OR. Okay? You start seeing this trend as we go through the lecture. What is this?
What's that?
Is it Great Turner or Holmes? I can't remember which one. That's one of the two.
It's,
Close. Close. What if I tell you who was riding his bicycle?
Oh, that's
It's a handlebar. Okay. When you see that, you think about the pancreas, okay? The most common mechanisms of bicycle handlebar. There's actually this triad, the classic triad. They have epigastric pain radiating to the back. It can actually palpate the mass, and they have acute peritonitis or ascites. Have we ever seen that on exam? Probably never, right? Especially in pediatric patients, they hardly ever come in with all three triads. How do we diagnose this? CT or labs. But it's important to note that elevated lipase and amylase are not as specific for pancreatic injuries, and actually they can take 72 hours for this elevation to come up, okay? But it's also important to know that in the absence of elevated lipase and amylase, you cannot rule out pancreatic injury. So labs are really not that helpful here. How do you treat this? Again, non-op management, bowel rest. You can do angiosuction if they're actively vomiting, persistent vomiting, IV fluids, and pain control. If they're stable, they go to the OR. Okay? Okay, now let's talk about abdominal wall injuries. Are we good? All right. So you can see hematoma versus contusion. Okay, if there's seatbelt sign, studies have found that if there's a 233 times higher risk for intra-abdominal injury. Let's look at that risk. That's really, really high. Gray Turners can be a sign for retroperitoneal hematoma, Cohen's intraperitoneal hemorrhage. How do you tell which one's which? I think of it as you're turning on your side. So Gray Turner is the flank one, right? And the other one, Cohen's, is the belly button one. Okay. Some people say Gray Turner has two words. You have two flanks. Whichever one is easier for you to remember. Turning. 2 words. But the key here is when you see those signs on exam, since there's such a high risk for intra-abdominal injuries, you want to get CT. Okay. What is this? Seatbelt sign. Yeah, this is the kid that I saw at Rady's a couple of days ago. She actually looks great. Look at the crayons. She was like ready, and she was like drawing on the Hello Kitty, and I had to take the Hello Kitty away. Anyways. Okay. Moving on to last category, hollow viscous. This is the most tricky one. It's only constituted about 1 to 5%. Most common mechanism is lap belt or bicycle handlebar. A lot of times you can see hematoma or edema, but you have to be concerned about perforation of the duodenum or proximal jejunum. Okay?
Quick question.
Yes.
In car seats, do you see a lot of seatbelt signs or not?
That one, the picture I just saw, that showed you, that was actually from a car seat. So it can certainly happen. Okay, what makes hollow viscous injuries so tricky to diagnose? Your initial physical exam may be completely normal. They can look great, no pain, not vomiting. And if you check any labs, it can be completely normal. Remember we talked about earlier, it can take 72 hours for the amylase and lipase to go up. Okay? CT is not sensitive for hollow viscous injury. So what do you do in this case? If the patient looks good, maybe with that handlebar sign, you have to do serial abdominal exam. Okay?
Is ultrasound used?
Ultrasound's even less sensitive than CT for hollow viscous injury. Okay, so how do we manage this patient? We kind of briefly went through this, but let's go back and just review some vital signs for pediatric patients. When there's blood loss, they compensate by tachycardia. And it's important to remember that hypotension is a very, very late finding. It's usually associated with at least 25 to 30% of blood loss before you see hypotension. Again, on belly exam, you look for any abdominal tenderness, signs of peritonitis, looking for any signs of bruising, ecchymosis. Again, we talk about this. There's such high risk of intra-abdominal injury. What about labs? So we kind of established the labs are not really helpful here. Hematocrit, again, not very helpful unless the first one you got is already significantly low, less than 30%. If in doubt, serum hematocrit or hemoglobins are much more useful. Same thing for LFTs, could be sensitive and specific for liver injuries, but again, trending is much better. Same thing for lipase. It's actually not that sensitive for pancreatic injuries. If you're really concerned, if there's ongoing belly pain, use it for trends. What about UA? You look for any gross or microscopic hematuria. Okay, and we'll talk about that a little more. So for adult trauma patients, we all start with FAST as part of our resuscitation, but FAST is not as adopted in pediatric patients. The utility is not as well established in pediatric patients. It's not very sensitive. It's very, very specific. Okay, it's operator dependent, and people will argue if it's positive FAST, what do? They either go to CT if they're stable, or they go to OR if they're not stable. So that's why people are not using it as commonly in pediatric patients. Versus CT is much higher sensitivity, the downside is radiation exposure, but sometimes you have to balance it out. So definitely consider CT if there's a serious mechanism, there's any abdominal physical exam, or there's concerning lab results. Okay? Okay, let's go back to the case that we talked about. So 9-year-old boy who fell over the handlebar, he had some pain. 7 hours later, he vomited a few times overnight. Vitals are pretty normal, not too bad. He has mid-epigastric tenderness. You don't see any ecchymosis, no abrasion, no signs of peritonitis. Okay, going back to earlier. Now that you know how to manage and what to look for abdominal trauma, what would you do? Okay. So it's kind of confusing, right? Because we don't really know what to do with this kind of patients. And wouldn't it be great if there's some kind of clinical decision rule that tells you, right? I know it's a little cheesy, but okay. So they do have this. So this was a group done by UC Davis. They're looking at some kind of prediction rule to identify pediatric patients with intra-abdominal injuries after blunt trauma, and that was published in 2009. So they enrolled almost 1,200 patients. This is a prospective study, and there's 6 criteria here. 1, low blood pressure adjusted for age. 2, tenderness on exam. 3, femur fracture. 4, elevation AST and ALT. 5, if they have more than 5 RBCs per high power fill on the urine, or the initial hematocrit is less than 30%. So applying those 6 criteria, they found 95% sensitivity. They missed 8 patients, and of the 8, 1 required laparotomy. So they found that if you apply to those 6 criteria, if the patients do not have any of those 6 criteria, we actually would reduce CT usage by 33%. Yes?
On the criteria, did it say abdominal pain or tenderness?
Tenderness.
And is that...
any kind of tenderness.
At any time?
Mm-hmm.
Any kind of tenderness at any time? Okay.
Okay. So if your patients don't have any of those 6, there's a 95% chance that you wouldn't consider intra-abdominal injuries.
It's amazing. I mean, you'd think that would be a specific rule and not a sensitive rule, right?
Right.
I mean, because these are some really significant findings. A femur fracture, crit less than 30.
Did they stratify that at all for mechanism, or just all comers?
Just all comers with blunt abdominal trauma. Huh. So they're pretty impressed with the findings, so they went on and applied that to extrapolate a little more. So this was published in 2012, again by the PECARN study with Nick Cooperman and the UC Davis group. So this time they did another prospective study. They actually involved 20 emergency departments. Look at the number of patients they have, 12,000 pediatric patients. So about 760 has intra-abdominal injuries, and the 761, 203 underwent acute intervention, which is defined as following. They need IV fluid for more than 2 days. They need blood transfusion. They have to have therapeutic laparotomy, or someone required angiographic embolization. Okay? And this is what they found. So they came up with this prediction rule. If there's any complaints of abdominal pain by history or in the emergency department, history of vomiting, GCS less than 14, abdominal tenderness, evidence of abdominal wall trauma. We talked about that. Remember the gray Turners, the seatbelt sign, Collins sign. Any evidence of thoracic wall trauma. Now there's seatbelt signs now over the chest wall. Decreased breath sounds. Okay. So they found that it's actually 97% sensitive, and if your patient doesn't have any of that, 99.9% of the time they do not have intra-abdominal injuries, but all the criteria had to be applied. And all missed patients had hematuria, which is more than 5 RBCs per high power field. Abnormal LFTs for hemoperitoneum detected by FAST. Okay, so when do we do CT? The patients go into OR, they're not stable, do we do it? No. Good. Seatbelt sign? Yes. Remember, there's 233% higher chance for intra-abdominal injuries. Gross hematuria? Yes, definitely. Microscopic hematuria? Maybe. We don't really know. Kind of depends on the overall picture. Depends on the mechanism. Depends on how the patient looks. So you can always use prediction rule. If you're not sure, if you don't want to take that 0.01% of chance of missing intra-abdominal injury based on those 6 criteria, you can add a UA, you can add LFT, and do it fast. If those are negative, pretty much you're good. Okay.
So you said that both of those were Cooperman articles.
Right.
The second one was kind of a refinement of the first.
Right.
Just like with with the head CT rules, we kind of, not for kids, we kind of use a little bit of American, a little bit of Canadian. I mean,
Right.
is that pretty much what the pediatric traumatologists are doing? Like you kind of, because they're different. I mean, they're not.
They're different.
They're different rules.
What I learned in San Diego trauma is really, really weird. So a lot of times at radies, we do A, B, C, D, E in trauma resuscitation, and a lot of times what I've seen is E is not for exposure, E is for ears. So I can't tell you. I can't tell you what's being practiced. I haven't seen this being practiced consistently. So I can't tell you that.
I mean, the second one was clearly the more powered of the two.
There's something to think about next time when you see a abdominal patient.
So can I just go back on the decision rule?
Sure.
If you look at it,
Actually, let me go forward.
Trauma, and it says any abdominal pain, any abdominal tenderness, any sign. I mean, it's most every case we're going to see, otherwise they wouldn't even be there.
Right.
So given that, they're going to have this decision rule. You're going to be doing the labs on everybody. You're going to be doing UA, you're going to be getting LFTs. Right. And then you'll decide if you have a negative FAST, I give it a positive decision rule.
Okay.
And he has no hematuria and no LFTs, you won't go to CT.
Essentially.
That's
based
sort
on
of how they're using the
based
rule.
on decision rule,
just
right?
Because they qualify by decision rule doesn't mean they get a CT.
No.
Most of the time, unless they're really have severe tenderness or something that's going to lead you there.
I think this decisions rule is probably better for ruling out because it has such a great negative predictive value. So your patient doesn't have any of that, and you did the additional.
Most of the kids are going to have something.
Right. Exactly.
This is like somebody who was in like a rollover with a fatality in the car, and the kid comes in and is totally fine, not complaining of belly pain, but has like maybe an arm fracture. You're going to say, hey, we probably don't have to go after the belly because of this.
Right. But again. Right, but again, it depends on the mechanism, depends on how the patient looks, clinical presentation, and
depends on the trauma surgeon.
Right.
Yeah, it's interesting because like Nexus, for example, that was ER literature. Then you had the traumatologist come down, ejected from a motorcycle at 100 miles an hour and like not a scratch on him, which you have, and with the discussion with the trauma surgeon. You go, well, he passes Nexus, and they're like, what the hell is Nexus? Get a scan. I mean, it's
right. So definitely there's education here. Okay, so going back to our case, our 9-year-old boy fell with a bicycle handlebar, initially asymptomatic for 7 hours. After that, developed belly pain, nausea, vomiting 4 to 5 times, and on your ED exam, he has tenderness over the mid-epigastric area, but no abrasion, no ecchymosis, no rebound, no guarding. Applying this prediction rule, so he has that, right? Here he has belly pain, history of vomiting, okay? And he has tenderness on exam. So you cannot use this rule, right? We established that. So what would you do? CT, okay. Any lab? Will anyone do labs? Yes, labs, okay. What about calling surgeons? Get surgery involved?
Stable, I mean.
He looks stable, right? He has stable vital signs. Looks good on in front of you. Just a little bit tenderness on epigastric area.
It depends what the CT shows.
Okay. So maybe get the lab and CT before calling the surgeons. Okay. Would you check a UA on him? Yes. Good. Okay. So just to let you know what happened with this case, WBC is 27. Electrolytes, LFTs, and lipase are normal. UA has no RBCs. Pain resolves spontaneously. And then you go back to tell them, mom and dad, like, let's get a CT scan, and after that, we'll try a PO challenge. And mom tells you he just ate this entire bag of Cheetos. No problem. So they actually decline CT scan. And patient looks great. We observed the patient, I think, about 4 hours in the emergency room, never vomited, tolerating POL, no fever. Serial belly exam is completely negative, and they discharged home with PMD follow-up. Okay, so like you can see here, every case is a little bit different, right? Okay, so remember, most intra-abdominal injuries are managed on non-operatively, okay? They go to OR if they're unstable, they require blood transfusion, or they have signs of peritonitis. Okay, take home points. Red flags, what do you look for? Belly pain, nausea, vomiting, any signs of abdominal wall, thoracic wall trauma. Look for that seatbelt sign, right? When do you do CT? If there's gross hematuria, seatbelt sign. If they're hemodynamically unstable, but they're still responding to fluid initially, versus if they're not responding to fluids at all, they require transfusion, or they have signs of peritonitis. They go to the OR. Okay. And you can also use low risk prediction rule, okay, in conjunction with your FAST, with your UA, and your labs. I think that's it. Serial exam, make sure that's key, especially for hollow viscous injuries. Remember, they can be completely asymptomatic, just like our case here, up until 6 hours, 7 hours, even 72 hours later. So make sure you do serial exam. A lot of times they may get admitted under our trauma service if the mechanism is very severe, and then you may just check serial lipase, serial LFTs, and serial belly exam. Okay? I think that's it. Any questions?
Awesome. Thank you. So one of the things